Has a doctor or another medical professional recommended to you or to a loved one a palliative care consult? And you thought, wait a minute, I'm not dying. They're not dying. Well, that's because palliative care is not just for the dying. In today's video, I'm going to explain to you in a way that you can really understand the difference between palliative care and hospice, what palliative care is, and how it works. At the end of the video, I will share with you an example of a patient that I worked with and his family that I think is like an excellent example of how palliative care can be pivotal in a patient's medical plan of care. Hi, I'm Nancy Lee. I'm a nurse practitioner certified in hospice and palliative care. I've spent the last 25 years of my career working with patients and families with serious and life-limiting illness. So palliative care is a medical specialty that focuses on improving quality of life, not just at end of life, but at any stage of a serious illness. It was born out of the hospice care model and became a medical specialty in 2006 in the United States. Hospice care is also focused on quality of life, but patients must have a prognosis of 6 months or less to live. Palliative care, similar to hospice, promotes quality of life by focusing on the relief of distressing symptoms like pain, shortness of breath, nausea, fatigue, appetite changes, anxiety, depression, emotional distress, spiritual suffering, and supports the families of these patients who are overwhelmed. Palliative care is different from hospice in that providers of palliative care also help with medical decision making, especially when the treatment path forward is unclear. Palliative care provides support through a multidisciplinary team made up of doctors, nurses, nurse practitioners, physician's assistants, medical social workers, and chaplains, recognizing the patient and the family as one unit, multidimensional, physical, spiritual, emotional, and psychological. Very similar to hospice, but the difference is palliative care and their and their team can provide support to patients with serious life-limiting illness at any stage of the illness, not just in the final few months. Also, while they continue medical interventions to prolong their life. Now, we all know that a serious life-limiting illness can be cancer, but they can also be heart failure, chronic lung disease like COPD, dementia, or renal or kidney failure. Those are just a few examples of other serious life-limiting illnesses. Medical science has improved approaches to chronic illness that is allowing people to live much longer with these diseases. These diseases used to end life within a few years, and now they can live extended amounts of time and years, but to what expense of the quality of life? Palliative care is designed to help people navigate these illnesses, helping them live the best quality of life alongside chronic serious illness. Not only are people living longer, but medical science has become so advanced, it is difficult to understand. It is found, and it's found that people who have a medical specialist to provide information and explain complex illness, as well as advocate for the patients when they are navigating this illness, is crucial to a successful outcome. Palliative care providers not only support patients through relief of distressing symptoms, but they are sort of a patient advocate as well, helping patients and families understand the details of an illness, the trajectory of an illness, what life expectancy is with this illness, given whatever stage the patient is in, and what one might expect on that journey. Through this kind of support, there's evidence to suggest that people live longer, have better quality of life, and they stay out of the hospital more. Speaking of the hospital, Palliative care was born in the hospital setting. That's initially how palliative care as a medical specialty came about. In the hospital setting, hospitals found that when a palliative care provider was involved in the care of people with serious illness that required complex medical understanding and decision making, palliative care providers are essential to help patients and their families navigate this successfully so that their wishes are honored and their treatment plan aligns with their values. Palliative care providers are seasoned experts in conversations that are difficult and hard around death and dying. Most doctors don't go into medicine expecting their patients to die. They go into medicine to promote longevity and cure from illness. Unfortunately, none of us are getting out of this alive. There does come a time when these illnesses advance to the point where survival is limited. Sometimes the patient is in the hospital more than they're out of the hospital, and they just don't want to do it anymore. Not only do palliative care providers help patients and families navigate their hospitalizations through the medical management for relief of these distressing symptoms that may be associated with their illness, they help them come up with a plan that identifies and reflects their goals and then advocate for the patient by facilitating and communicating that plan to the other medical specialties that are involved in the patient's care. Palliative care providers have the time and the skill necessary to sit with patients and their families for as long as it takes to know patients as individuals, not as a disease. Make sure the patient is informed or that the family is informed, and that these decisions can't be made about medical care if you're not informed about what that care looks like. I have mentioned that there comes a time in a patient's disease trajectory where patients get tired. They're tired of being in the hospital. They're tired of being sick. They have poor or very little quality of life. And our medical culture is such that medical providers tend to prolong life at any means possible. Palliative care providers can help patients and their families recognize when perhaps they are nearing that time in their life and advocate for them with the other medical providers. Palliative care teams have become very important in the inpatient hospital setting, with 95% of large hospitals employing a palliative care team. Many of the other medical specialties like cardiology, pulmonology, gastroenterology, renal or nephrology specialists, they've all become very reliant on palliative care teams to help their patients traverse and navigate serious illness. And what I want to emphasize, when you or a loved one hears that you need a palliative care consult, do not think that it's because they are imminently dying. It is because a medical specialist has recognized the seriousness of the illness and the toll it is taking on the patient, and that they know that palliative care providers are skilled at helping patients understand where they're at, what they can expect, and knowledge is a powerful thing. Not only do palliative care providers make recommendations and prescribe medications and procedures to alleviate distressing symptoms that often accompany chronic illness, I want to share a story with you about a family that has always stuck out in my mind as an excellent example, and a very dramatic for me example of how palliative care can be pivotal in a patient with serious illnesses, medical plan of care, and their life. So for the sake of anonymity, of course, I'm not going to use the patient's real name, but we will call him Mr. Smith. Mr. Smith was an 86-year-old man who had been admitted with recurrent congestive heart failure after having been discharged just 10 days previously for the same exact problems. We received the consult in palliative care for the family to establish goals of care. Now, palliative is often consulted by other medical specialties in a patient, an elderly patient who has bounced back to the hospital, who has a serious life-limiting illness, especially when that patient has bounced back or been readmitted with 2 or 3 times within a very short amount of time, because that is associated with elderly people in their last year of life. So Mr. Smith, 86-year-old male, admitted with recurrent, uncontrolled, decompensated symptoms of heart failure. Now, I don't want to get too technical here, but just in layman's terms, symptoms of heart failure are like the heart muscle gets very tired and it fails to work properly, and that results in fluid retention, shortness of breath, and an assortment of other symptoms. If it's left untreated, it eventually leads to death. Palliative care consults normally come from another medical specialty, as I described, but sometimes we will get a request from a family. Now, this particular patient's request for palliative care had come from the family. It's very exciting to see this, because that just means that more people are beginning to understand how palliative care can help them in a medical crisis. So I went to meet with Mr. Smith and his family in his room. He was 3 days into this hospitalization, and cardiology had been tweaking his medications to address his heart failure. Upon entering the room, the patient was awake, alert, and conversant. His wife and daughter were bedside. I always introduce myself as a nurse practitioner with palliative medicine, the palliative medicine team that has come to answer questions about anything to do with the hospitalization and make sure that their needs and concerns were being addressed. I try to be as non-threatening as possible, because I have also been thrown out of people's rooms because they think I am there because I have been called and told that they were dying or their loved one was dying, and that's just not true. I mean, sometimes it is true, but the majority of the time it's just not true. So within just a couple of minutes of entering this room, I was able to assess that this patient was pleasantly confused. I was unclear if this was his baseline or part of his symptoms related to his ongoing heart failure. When patients are confused or have an altered consciousness, I will take the family separately outside of the room, so that not to confuse the patient more or to alarm them. So we left the room, went to the family waiting room, where I had a long conversation with his wife and his daughter. They shared, both the wife and daughter shared medical health power of attorney, which just means they made joint decisions for the patient. They made decisions for the patient medically jointly. So we reviewed his history and what led to this hospitalization and his story. The patient's wife and his daughter, they were noticeably emotional, somewhat distressed. The patient had been diagnosed with early stage dementia several months ago, but since his heart valve, he had a heart valve replacement 2 months ago, and since that replacement, his cognitive function had declined noticeably. The wife spoke really eloquently about the patient, and that during his years of wellness, he and she had discussions about their healthcare advance directives and what they would and would not want done medically in light of a serious or a life-limiting illness. Now, the patient's wife indicated that the patient's overall health, but especially his cognition, had dramatically declined, that he was not himself. She went on to say that he was the most wonderful human being and had been married to him for 54 years. She knows him. She knows what he would and would not want, and he would not want his life prolonged in a state of cognitive decline. She was appropriately emotional, and her daughter agreed with his wife. The problem was the healthcare team attending the patient's illness during this admission were focused on his heart, and they weren't looking at the big picture, the overall declining neurological and cognitive status. In fact, the family was somewhat distressed that such aggressive medical care was being carried out in response to heart failure, leaving the patient with a better functioning heart, but in a state of more advanced neurological decline. With this in mind, the family requested that what alternatives, they were asking, like, what alternatives were available to adjust his medical care. They wanted to focus on more of a quality of life model. So we went over the details of that, and I recommended that he be enrolled in a home hospice program to prevent rehospitalization. I explained and went on to explain that inevitably his heart would begin to fail again, and he would likely be readmitted within a short amount of time. And if their desire was to redirect his medical care to quality of life, it would be appropriate to pursue a hospice home program. We discussed what changes had been implemented by cardiology to optimize the patient's heart function, and actually they were continuing to titrate these measures. The family asked me to speak to the rest of the medical team and tell them what their goals and their values were. It was not in optimizing his heart function, only to have him continue to decline neurologically, resulting in a very poor quality of life that is not what he would have wanted. So we began discharge planning. And we walked back to the patient's room, and again, the family was really appropriately tearful. So they weren't like trying to do him in or anything. They were appropriate. They just wanted to honor what they knew his wishes would be. And I had a sense that it was with great love that they made these decisions. And so as we were walking back to the room, the patient's wife stopped me and she said, "You were sent to me by God. You were an angel." And she thanked me for validating that it was okay to honor what the patient had voiced earlier in his life, that he would not want this medical plan of care in the event of the situation in which they found themselves. Now, I have to tell you, for a family to go up against a hospitalist and a cardiology team and ask to change the plan of care and to stop aggressive measures takes a lot of courage, but it also takes a lot of love. After I left the family, I was able to talk to the other medical providers involved in the patient's care, who humbly agreed to begin discharge planning to a home hospice. I'm going to tell you, like, it's this kind of interaction with a family that, like, lets me know that what I'm doing makes a difference. Not only was I able to align this family or this patient's medical care with his wishes, I was able to validate for this family that, yes, in fact, it was certainly rational and reasonable to honor who they knew the patient to be. Now, I'm going to tell you that palliative care is consulted for patients who need hospice. So palliative care are experts at opening the door to those conversations. So, because hospice has become associated with imminently dying, giving up, and failing. I'll have another video about that topic because that is not what hospice is. But there are times when a medical team recognizes the patient needs end-of-life care. For whatever reason, they're reluctant to accept it, and so palliative care providers get involved to help the patient and the family explore what they have questions about. Explore their understanding and help them come up to terms realistically in line with the nearing of end of life. Helping them to consider shifting the focus of medical care from a meaningful recovery to focusing on a meaningful, dignified, and peaceful death. This is a very individualized process, and every individual approaches this differently. Palliative care providers are aware of this, and when they meet with a family and explain all the details of imminently or not or approaching end of life and they are not there, palliative care honors that and then advocates for them with the other medical providers. They help them continue to seek out care that aligns with their values, and it's perfectly okay. Every individual should be educated and informed about where they are in their disease process as they near end of life. And palliative care providers are just experts in doing that. Now, as I said, palliative care was born in the hospital. You see most palliative care providers in a hospital setting, but there are home palliative care programs offered for folks with life-limiting illness to help the same sort of navigating issues that come about in a hospital setting. Many of those programs are affiliated with their own hospice in hopes that the patients will have a seamless transition to hospice when their prognosis is 6 months or less, and they agree with the philosophy of hospice, which means no longer seek aggressive medical treatment. Now, I have really simplified this conversation, but it's my hope that this has shed some light on what palliative care is, how it works. You are welcome to ask questions about anything to do with palliative care in the comments, and I'll be happy to answer them. Thank you for watching, and I will see you in the next one.